ready?
So Bill, you're going to show me something about suboccipital releases?
Yes. Okay. So the reasoning behind doing a suboccipital release has always been sort of like a symptomatic kind of a thing, or somebody complaining of tightness kind of a thing. And there's actually very specific signs that you can identify to identify whether you need to do one manually or not. And there's two different kinds, so you have to know which one you're doing and at which time. Thankfully, Nikki's decided to be incredibly asymmetrical today, so we get to do both. So I'm pretty excited about this.
Great.
But bring the camera in. Let me show you the two different kinds. So there's going to be a decompressive one, and then there's going to be one that's going to be compressive. So the decompressive. So typically, what you would do is you come underneath the occiput, and you go into the soft mushy stuff here, and you sort of capture the space between the occiput and C2, because that's the easiest one to find, and it would do some sort of a distracting kind of a movement here, and that would be version 1, where I'm actually trying to decompress this area by actually pulling superiorly on the occiput. The other kind would be where I'm just going to sort of occupy this space, and I'm going to let the occiput extend over my fingers, which would be more compressive. Okay, so if I had a concentric orientation of the suboccipitals, I would want to use the distracting element to try to create an eccentric orientation to create space, add fluid volume into that space. If I already have eccentric orientation, then I'm going to use a more compressive strategy where I'm actually going to press on that area, and I'm going to try to capture the occiput extension. So those are the two different kinds of releases.
Gotcha.
Now, how do you know which one to use? Well, like I said, Nikki has decided to be very, very asymmetrical. So you can move around if you need to, Mike, to make sure that we get all this on camera, because I got to go in front of you actually. So,
Gotcha.
So why don't you flip-flop me here? Okay. So the typical signs you're going to find. So first and foremost, we wouldn't do this as our first strategy.
Sure.
What we would do is we would give Nikki an opportunity to make the changes herself with some form of activity before we would apply any manual therapies whatsoever. So we're going to make an assumption that Nikki's attempted to do something. We picked the appropriate intervention. It didn't go well. We didn't get the changes that we want. But here's going to be the typical restrictions that you're going to see. All right. So So if I take Nikki into hip flexion, I feel resistance about right there. And so we're just about maybe 100, 105 tops. So I have a limited hip flexion, and I'm going to have a limited shoulder flexion on the same side. So as I take Nikki into flexion, you can see she starts to internally rotate right there. And so that's the limitation that we're going to see. So right away, my assumption is that the lower cervical spine is actually turned to the right, occiput's turned to the left, which means I have a compressive strategy on the left side of the upper cervical spine at the occiput. So I'm going to use a distracting mobilization on the left side. Now, if we go over to the other side, and I take her into hip flexion, right away it's softer, it's much easier for me to move her into hip flexion. So this is less restricted, and I have this great element of shoulder flexion relative to the other side. So my assumption on this side is I just have the opposing strategy, right? So she actually does have cervical rotation to the right, and she has occiput turning to the left. So I have an eccentric strategy in the suboccipitals on this side. So I'm going to use it more of a compressive. So I can do both of them at the same time. And then my goal is that after we do this intervention, that we will see Nikki sort of flip-flop or move us closer to what we would expect to see from a normal mobility standpoint. Okay, so I'm going to go ahead and I'm going to do that, and then we'll shoot the next video.
So Bill, what are these two techniques?
Okay. All right. So I'm going to come up underneath her occiput. On the left side, I'm going to use a distracting force. So I'm going to actually be pulling towards me. And on the right side, I'm just going to move straight up into the soft tissue that is eccentric oriented. So left side is going to be concentric oriented. I'm going to use a distracting force. I'm just going to use a compressive force on the right side. So it'll look the same as I come up underneath her head, but she's going to feel the difference almost right away.
Gotcha.
So lift your head for me, and then just rest your. So I'm supporting her occiput on the thenar and hypothenar aspect of my hand, right? I'm coming up underneath there. Oh, this is going to work really, really well. And so she's going to feel that. So you feel the distraction there, and then I feel the straight up there. So there you go, right? And there's other ways to confirm this too. So I'm just going to hold this while she just responds to this. So if I wasn't sure as to which way I could check this, what I would have her do is tip her head backwards with her teeth together, and then have her release her teeth and let her head fall back. And what you would see that the cranium would actually turn left as she did this. I could also use the mandible as a guide, because what I would have is I would have mandibular deviation to the left. So as she would protrude her mandible and from right and left lateral trusion, she would have more to the left than to the right. And so it doesn't matter how I would perceive this in this case, because she is asymmetrical. So I have, again, the distracting force on the left, compressive force on the right. And so if I was trying to affect the right side, I would have the limitations on the left with the hypermobility of the mandible to the left. If I was trying to affect the left side, I would still have the same findings of the limitations on the left, right?
When are the times where you would want to attack one versus the other, like the right versus the left, or the decompressed side versus the compressed side?
In this case, I would always
You're just going to
basically do both, because
Okay.
what I'm trying to do is restore variability. I'm not really dealing with a specific diagnosis, although your patient may come to you with, say, left occipital headaches or occipital neuralgia diagnosis on that side. You feel the difference in the two sides? Yeah, that's pretty good, doesn't it? Yeah, there it goes. So, and then you start to feel change over time. And so all we're getting is a shift of fluids and a little bit of a change in muscle activity. So she's starting to eccentrically orient on the left, and then we're going to gain some concentric orientation on the right, just through the compressive force.
So
right?
we see patients that have that kind of limitation all the time, but we're not necessarily doing this technique on everyone. We're just doing it on people that would have symptoms associated with that area.
No, but so think about this for a second. So what if I had somebody that came in with a hip impingement and the same findings, and I'm struggling, I can't find a way, right? Or she would have a limited straight leg raise on the left compared to the right. And so again, all of these findings, and you'll see this in the literature, you'll see the straight leg raise change with messing with the suboccipital region. There's actually a fair amount of information there, so you'll see it. And so this is one of those relationships that is at each level. So the flexion in the hip, the flexion in the shoulder, and then the position of the occiput.
Gotcha.
On the cervical spine. So this is probably pretty good. So leave it run. Just change reposition.
Mm-hmm.
And so now it's going to be like crazy soft. I know, it's like a magic trick, isn't it? Look at this. And you feel it?
Yeah.
Yeah, it's pretty cool, isn't it? So just by, again, but your whole system responds the same.
Mm-hmm.
So at each level of iteration, so the pelvis and the thorax are the same, the cranium is the same.
Mm-hmm.
And so if I affect one, I affect the other. And that's basically what we just did. And so you get to see the change in both. So pretty cool.
Mm-hmm.
There you go.
Thank you.